what are the treatment options for patients who need treatment. So what are the things to consider? First, we have to establish the treatment goals. We need to establish the prognostic factors, which I just described. And we need to decide what to do next. When do we start chemotherapy or other therapies? Do we choose standard therapy, which is selected based on years of clinical trials, usually phase 3 trials, and we'll go over that, or do I want to try something different? So enroll on a clinical trial that gives me the option of trying new therapies or other combinations that would not otherwise be available to me. So one strategy is to watch and wait, and it's a strategy that is used in patients who are not having any symptoms. There are many different ways of calling it. Some people call it watch and worry, especially if it happens in a young patient. But there are patients that are elderly in their 80s, and they just found on a routine blood test that they have lymphocytosis. They could be watched. They may never require therapy. The rationale for deferring therapy is because it doesn't impact the overall survival of the patient. In somebody who doesn't have any symptoms, starting therapy will introduce symptoms. So as a first rule in medicine is to do no harm. We don't want to make the patients feel worse, and there's no survival benefit. Therefore, we're not going to institute therapy if there's asymptomatic and they don't have organ dysfunction. The other thing is that usually your drug regimen that you use first will have the biggest bang for their buck when it's used the first time. Meaning that if you have an 8-year remission with your first-line therapy, the second time you use that drug, you're unlikely to get 8 years. You're going to get a shorter remission. So we really want to use the drugs when we need them. And when do we need them? We need them when patients have symptoms. Okay, and we went over them. Organ dysfunction, so marrow dysfunction, commonly it's thrombocytopenia, anemia, neutropenia. Occasionally, it's if the lymphocytes are growing at a very fast pace. So if the doubling time that we see is shorter than 6 months, that can be an indication for starting therapy, because we anticipate that they will have organ dysfunction in the near future. And there could be complications from CLL that are not responding to therapy, okay, like autoimmune dysfunction. One important consideration in initiating therapy is the patient's age. And that is because their resistance or their ability to tolerate chemotherapy is very different in a patient who is 80 years old versus a 40-year-old patient, okay? And most patients with CLL are diagnosed after they're 60. So it's 60, 70, 80, but nonetheless, we have quite a few patients that are young and they could tolerate more aggressive therapies. And so the goal is to do no harm if the patient is elderly and frail and can't tolerate the side effects of therapy. However, if they're young and fit, and we'll go over what that means, then the goal is to achieve a deep remission, to have a prolonged period of time where this person can return to work, have a normal quality of life. That is your goal. It is possible that the CLL will not come back, but it's also possible, we have to be realistic, that in many occasions it does come back. So the goal is to not cure, but to have a deep remission. And in those in between, unfit or patients who are older than 65, we really have to weigh the risks and benefits of the toxicity. So we want to have something that works well, but is not going to be too toxic to the patient. We are in an era in 2017 that we have a lot of options on the menu. This was not always the case. In the 60s, after the First and Second World War, we developed chemotherapies, and the earlier chemotherapies are called alkylating agents, and they bind and they disrupt the DNA. And examples of this are chlorambucil or cyclophosphamide, which we still use to this day because they work. But the ability to attain a complete remission, CR, is a complete remission, meaning that there's no evidence of disease, is only 5%. In the 80s, there were new chemotherapy agents called purine analogs, okay? And these mimic the components of the DNA, and they also, in some, you can imagine it that it disrupts the DNA because it competes with the normal components of the DNA, and they were also very effective. In fact, fludarabine, which is what we're going to talk about, has been shown in trials to be superior to the alkylators as just like head-to-head comparison. They had a higher complete response rate, 25%. Based on this, next logical step is to combine both and say, we're going to combine a purine fludarabine with cyclophosphamide and see if that is better, which it was. So that is FC, so 35% response rate. And then in the 2000s, there was an antibody called rituximab that binds to the B cells. And it has been effective in multiple lymphomas, and they of course decided to compare rituximab and chemotherapy, so FCR versus FC. And so this has been really the keystone therapy for CLL. I mean, I'm not going to go over all the, of course, different therapies were used, but really that is the one that was designed at MD Anderson and the one that is the most, I would say, considered the gold standard for young, fit patients. In the 70s, we are able to have a higher overall response rate. ORR is overall response rate. It includes complete responses and partial responses. And we are able to improve the progression-free survival, so the duration of being in remission. And, but we still are not at the point where we can improve the overall complete response rate beyond 40%. The decision to have standard therapy or a clinical trial is a personal one, and one that should be discussed with a patient and their physician. The standard of care is based on previous clinical trials. So the standard of care very rarely involves something that's off the cuff that hasn't been shown to be effective. It is offered in most hospitals, and it involves less testing for the patient, fewer scans, okay? And it's somewhat easier, fewer visits to the hospital. A clinical trial will give you an access to a different type of therapy. It can be very high risk, high gain. It involves much more rigorous testing, and Tracy Rijabal will talk to us about that in more detail. The main difference between the trials are the questions we're trying to answer. A phase 1 is usually first in human. Is this drug safe? Phase 2, the question we want to answer is this drug effective? And phase 3 is this better than the standard of care? And they usually compare one to the other. Although phase 2 can have several arms, comparison arms, but broadly, this is what we're trying to answer when we're doing clinical trials. What are the differences between conventional chemotherapy and the novel agents? The main difference is the way they kill CLL cells. Okay, so chemotherapy, we went over this before. The main way it kills its DNA, and because it's already genetically sensitive, it will then trigger p53 to say, you must die. Okay, so this is it creates a situation where the cell can no longer survive. They die because they're too damaged. The novel agents have different mechanism of actions. They don't often require p53 to be active, and we'll go over that. There are multiple new drugs on the market that are approved by Health Canada. There's bendamustine, which I don't consider a new drug, but bendamustine is a chemotherapy agent that shares some properties between fludarabine and cyclophosphamide. So one can conceivably think of it as FC together, but have just the cytotoxicity, the side effects of one drug. Obinutuzumab is a new anti-CD20 drug, and we'll go over that. It's ibrutinib. Those three drugs, ibrutinib, obinutuzumab, and bendamustine, are now approved by Health Canada, and we can have them in Quebec as first-line therapy for CLL. Idelalisib and venetoclax are approved, Health Canada approved, for the treatment of relapse CLL. So upfront, so I'll go over the upfront and relapse setting. So what does rituximab do? A very easy acts like a flag to target it for immune destruction from the other immune cells. Okay, so it will bind to CD20 protein on the surface of the cells, and this event will have your T cells and your macrophages identify it as having to be destroyed, and so that it's called cell-mediated cytotoxicity. There's another way it could be complement-mediated cytotoxicity, but essentially it's an immune destruction, and very little of its effect is directly killing cells. Okay, direct cytotoxicity. Very few cells are directly killed by rituximab. Nonetheless, when we combine rituximab to fludarabine and cyclophosphamide, we see that it's much more effective than just chemotherapy on its own. And the critical trial that showed this is the German trial, the CLL trial, which enrolled over 800 patients. We use this for patients who we qualify as fit, young, normal function, like all the organs must be functioning well. The liver, the heart, the lungs, the kidneys. But this only applies to about 25% of patients with CLL. About 45% go into complete remission, and the duration of response is 4 to 5 years. Average duration. Some patients are much longer, some less. But it is toxic. 60 to 80% will have immediate toxicity. I call this short-term pain for long-term gain in some patients. They will not like chemotherapy. Most patients actually don't like chemotherapy, but they will, about 60% will have grade what we call 3 to 4, meaning that they will end up in hospital from side effects from their chemotherapy. The most common being neutropenia, right? So infections. In clinical trials, there's a mortality of 2 to 5%, although in clinical practice, this is not usually seen. 20% of people don't finish all 6 courses. And there is a long-term toxicity. There are some patients that have prolonged neutropenia and thrombocytopenia. And really 5% have a risk of long-term cancer from the bone marrow from exposure to fludarabine. Okay, so 5%. So that's the number that 5% will have long-term toxicity from chemo. Many patients will have short-term toxicity from chemo, but we know the effect. The long-term side effects of chemo are really well known. And there are patients that really benefit from this. They get 6 months of chemo, and then that's it. They're done. They return to their normal life. If the patients have a mutated immunoglobulin gene status, 60% will still be in remission at 8 years. And in fact, there are further studies that show that if you have no evidence of disease by more sensitive monitoring, so we call this minimal residual disease monitoring, if patients are MRD negative, meaning there's no evidence of disease, and they have a mutated status, 80% will be alive after 8 to 10 years without any evidence of relapse. So that's actually, there's a good group of patients there that would benefit from long-term remissions with FCR. Like I said, FCR it's hard, it has some toxicity, so other regimens have been used. Bendamustine was compared to FCR, and in young patients, FCR wins. So if you're able to tolerate the toxicity, it's better to have FCR. However, in patients who are greater than 65, the toxicity outweighs the benefit. Okay? And so what you can see here are survival curves for patients who were treated with FCR and patients who were treated with BR. And if you compare, BR is the red and purple line, FCR is blue and green, so green superior. However, there are two lines that I want you to focus on is the red line here, which is BR in older patients, and FCR in older patients, and there is minimal difference there, not statistically significant difference between the two in terms of efficacy, but in terms of toxicity, it's much easier to get BR. So it's a very reasonable to treat patients who are older with with BR. So what are the other options? I told you about the new anti-CD20 antibody called obinutuzumab. There are different ones, but this one is the one that was, I would say, more commonly used. And this is different than rituximab because it can directly kill the B cell. It has more direct kill effect. It still has the antibody, the immune component, but when patients receive this, they can have a rapid clearance of their CLL cells in the blood within a matter of days. And that, when they get the obinutuzumab, they are at risk of getting, in fact, an infusion-related reaction, to have this rapid clearance of your CLL cells in the blood. However, once that occurs, those immediate side effects, it is usually very well tolerated for the following cycles of therapy. And so the CLL-11 trial compared the use of this antibody with chlorambucil, patients that they felt were not eligible to get FCR. So they compared something less toxic, chlorambucil versus chlorambucil and rituximab, and chlorambucil versus obinutuzumab. And what you could clearly see on the left is that adding this anti-CD20 antibody is much more effective than chlorambucil alone. So in other words, easy chemotherapy versus easy chemotherapy and an anti-CD20. And it is superior than rituximab. So the orange line here is, there's chlorambucil versus chlorambucil and rituximab here, and then chlorambucil and GO101 or Gazyva or obinutuzumab. the effect is more pronounced in patients who are treated with the newer antibody. There's no difference in overall survival between the two, but you could see that the complete responses are deeper. Okay, so the purple, what you want to look at is the purple, in patients who have the GA101 or the obinutuzumab versus the rituximab arm. And so overall, this is a summary slide of how you approach patients in terms of the first-line treatment for chemotherapy. You want to balance efficacy and toxicity. So the more toxic, short-term toxic regimens, FCR and BR, are the most effective, and those that have the least toxicity also have the shortest duration of remission. So in patients who are not candidates for FCR or chemotherapy, one option is to give ibrutinib, which targets BTK, and it will stop B-cell signaling. Why is this an option? In fact, it's a treatment option in patients in the U.S. Many patients who have CLL are on ibrutinib. Why? Because they compared ibrutinib to chlorambucil in patients who are older and not able to get FCR, but they excluded patients who had 17p, and this is the RESONATE-2 trial. And you could clearly see there's an advantage to the ibrutinib arm in terms of progression. So what you're seeing is the progression-free survival, the duration of response. However, very few people on ibrutinib get a complete response, meaning complete clearance of their lymph nodes, of their lymphocytosis. In fact, only 5% attain a complete response. So people who are on ibrutinib, they have to take ibrutinib every day until progression, knowing that there's still CLL cells in the and you should not stop the ibrutinib because there's a higher risk of progression. Ibrutinib also is, it targets BTK, but it's now understood that it targets other kinases, other enzymes in the body that have a similar structure to BTK. 19 others, in fact, and these could have side effects. So if you look at all the side effects from the trial, they'll all be very similar. There's going to be some neutropenia, some nausea. We have to record meticulously everything. But these are side effects that are probably what we call off-target effects, meaning that ibrutinib is it's not a BTK effect, it's an effect on another enzyme in another organ. And the most serious would be cardiac arrhythmias, people who are can go into atrial fibrillation, and more recently it was described ventricular arrhythmias. So this is better appreciated now that it's being used more commonly in real-life scenarios. It's also increasing the risk of bleeding, so people can present with bruising, but more serious bleeds as well. It is approved in Quebec for the treatment of 17p deleted CLL because it doesn't act like conventional chemo. And why is it approved? Because it was compared ofatumumab, it's another CD20 antibody, in the relapse setting. So you could clearly see the ibrutinib arm wins. But many of these randomized trials use a comparator where it's very difficult because we know that there are not many effective drugs in this setting, in the relapse CLL. Very few physicians would use ofatumumab to treat relapse CLL. So it's kind of comparing it to to some extent, a placebo. So you know that the ibrutinib is set up to win.